All right, well, thanks for having me. I am happy to talk a little bit today about using surveillance data to identify molecular clusters for investigation and response. Next slide. Next slide. So it's important to identify growing clusters of recent and rapid transmission in order to intervene and interrupt transmission. And so you'll hear me talking about a transmission cluster a lot today. A transmission cluster is a group of HIV-infected persons who have a direct or indirect epidemiologic connection related to transmission. And this can represent recent and ongoing transmission in a population and indicates that public health interventions could improve care outcomes and prevent new infections. Next slide. So there are a few different mechanisms to identify transmission clusters. First, a jurisdiction might notice an aberrant increase in HIV diagnoses in a particular geographic area or a particular population, and that could use case surveillance data. This kind of approach is particularly useful in areas with low HIV prevalence, but could also reflect an increase in HIV testing that has diagnosed people whose infection may be longstanding. Another approach is analysis of HIV sequence data reported to HIV surveillance, and typically those are molecular surveillance data. This approach is particularly useful in identifying transmission clusters that are not detected through other mechanisms, those occurring in an area with a high incidence of HIV infection, and those involving multiple jurisdictions. HIV partner services and contact investigations can also uncover transmission clusters, but may be limited by completeness of elicitation of partner information. And then finally, sometimes healthcare providers, health department staff, or community members may become aware of a situation and raise that to our attention. Please click. Next slide. Okay. So I'll be focusing on molecular surveillance data. It looks like perhaps my animations might not be in here. So in the United States, drug resistance testing is recommended for all HIV-infected persons and generates HIV nucleotide sequence data. Harnessing these nucleotide sequence data can provide information on transmission relationships and allows us to identify growing clusters that represent active transmission. Next slide. So the National HIV Surveillance System is the primary source for monitoring HIV infection in the United States, as you know, and we use it at federal, state, and local levels. Next slide. So this is an updated version of a slide that you guys may have seen in the past about monitoring the spectrum of HIV infection. So the National HIV Surveillance System really monitors a variety of different things. So traditionally there are events ranging from HIV exposure to infection to diagnosis, to first CD4 viral load, subsequent CD4 viral load, as well as drug resistance tests and death. Throughout this time period, we can also monitor stage of infection, including early infections such as stage 0 or acute, and stage 3 or AIDS. We also monitor the spread of HIV through identifying transmission clusters and outbreaks. This is a newer area for us and what I'll be focusing on today. And then, of course, we are monitoring care, looking at undiagnosed infection, entry to care, and retention in care and viral suppression. Next slide. So molecular surveillance is a component of the National HIV Surveillance System that involves collecting HIV nucleotide sequences, antiretroviral use information, and pairing that with all of the demographic risk and other case information that comes in through case surveillance to assess drug resistance, transmission patterns, clusters, and genetic diversity. Next slide. So these are the jurisdictions that currently conduct MHS as part of our current FOA that's from 2013 through 2017, and there are currently 27 jurisdictions. This will be expanding under the new FOA. Next slide. So just briefly how we collect nucleotide sequences. So as I mentioned, drug resistance testing is a standard of care. So people with HIV go to their HIV care provider who orders drug resistance testing, and a specimen is collected and sent to the laboratory. As part of genotypic testing or Sanger sequencing, a genetic sequence is generated and compared with a reference sequence to see if there are mutations. And those mutations are identified and then interpreted to understand whether there is the presence of mutations that are associated with drug resistance. What the provider gets back is a resistance report. But what we get through molecular surveillance is that HIV sequence, which is an intermediate byproduct of this process. And that's reported electronically to health departments and then on to CDC in a de-identified form. So there are a number of ways to use molecular data. I've touched on these briefly, but monitoring drug resistance, both transmitted and acquired, examining subtype diversity, understanding transmission patterns, corroborating, refuting, and understanding suspected outbreaks. Some of you may be familiar with the use of molecular data to understand the Indiana outbreak. Identifying possible outbreaks and triggering investigation and intervention, monitoring those outbreaks over time, and prioritizing prevention efforts. So I'm focusing on identifying possible outbreaks for investigation and intervention. Next slide. So molecular epi and HIV, why can we even do this? Well, HIV mutates or evolves over time. And so people living with HIV infection whose viral strains are genetically similar may be more closely related in transmission. So for example, you can think about this like a game of telephone where the first person might say la 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 la. And in a game of telephone, errors are made and words are said wrong. And so that becomes la 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 ra la 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 la, which might become la 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 ra la 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 ya, which might become la 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 ra la ma la la ya. And so if we look at the first and the second string of laws, we see that there's one difference, but they're pretty closely related. If we look at the first and the last one, we see that there are three differences and they're not as closely related. And so we do something similar with nucleotide sequences to determine relatedness. Next slide. So to identify transmission clusters, we start by comparing all pairs of sequences to calculate genetic distance between them, which is a measure of how similar they are. We then identify pairs of sequences that are very closely related and connect all closely related pairs to identify clusters. So for example, if we have sequence A and sequence B and they're very closely related, we'll draw a line between them to indicate that relationship. And we do this using HIV Trace, which was developed by University of California, San Diego. And we end up with clusters that might look something like what you see on the right of the screen. Next slide. So when we identify a pair of sequences that's closely related, it's important to think about what we can and can't say about them. So if person A and person B have very similar sequences, it's possible that person A infected person B, but it's also possible that person B infected person A. But another option is that maybe person A infected person C, who then infected person B. And if we don't have a sequence for person C, we might just see a relationship between the sequences for A and B. Or likewise, there might have been a person D who infected persons A and B. And if we don't have a sequence for D, we might just see that A and B are closely related. So we can infer that there's some sort of epidemiologic link, but it may be direct or it may be indirect, and we cannot infer directionality. Next slide. So let's just think about what we're thinking about when we find a molecular cluster. So let's say that we find this hypothetical cluster of 4 people that are identified through sequence analysis. Next slide. What that really represents is a part of the cluster. So a transmission cluster that we identify through molecular analysis only includes those cases that have been diagnosed and have a sequence. And this represents a subset of the underlying transmission cluster and risk network, which can also include a variety of other people, including people who are diagnosed but don't have a sequence in the analysis because they were never linked to care, or they were linked to care but they didn't get a genetic resistance test, or that sequence didn't get reported to the health department. Could also include people with undiagnosed infection or HIV negative contacts who may be at risk of acquiring HIV. Next slide. So the underlying sexual and risk network that corresponds to that molecular cluster may look something like this. So we have those 4 people that were in the molecular cluster, but there are a lot of other people as well that are diagnosed, undiagnosed, or not infected. Was there a question? No. All right, next slide. So what are we doing at CDC to identify active transmission clusters? We actually analyze our data quarterly to identify growing clusters that represent recent and rapid transmission. We really detect quite a lot of clusters in our national analyses, but we prioritize these clusters to identify the most concerning clusters nationally. So we look for very tightly related cases, which suggests rapid transmission because transmission is occurring rapidly enough that the virus hasn't had time to evolve. We also look for at least 5 cases in the cluster that were identified in the most recent 12-month period to get at the rapidity of transmission. And so as an example, our first analysis of data at a national level was on data collected through December 2015. And we found 1,900 clusters, but of these, there were 13 that met our criteria for rapid growth, with at least 5 cases in the most recent 12-month period. These clusters occurred in all regions of the country, and several clusters consisted of drug-resistant strains. Next slide. So we actually have done some analyses to understand how active the transmission is within these priority clusters. So the estimated transmission rate for the United States is approximately 4 transmissions per 100 person years. So that means if you followed 100 people with HIV for a year, you might expect to see approximately 4 transmissions on average. We estimated the transmission rate for these 13 clusters and found that the transmission rate was 35 per 100 person years. So this is more than 8 times that of previous national estimates, and really indicates that these clusters likely reflect the leading edge of HIV transmission. And this kind of rapid transmission likely leads to a disproportionate number of new infections, and really indicates that it's important to initiate investigation and intervention for these clusters. Next slide. So when we identify high priority clusters, we start by creating a cluster snapshot. And this is a document that includes maps and epi curves and tables and line lists that allows us to discuss these cluster findings with relevant state or local health departments and communicate and collaborate with them on investigation and intervention. So quarterly updates provide information on new cases added or previously identified, to previously identified clusters, and also we identify new clusters meeting the priority criteria for the first time. So we've analyzed data for 7 quarterly data sets so far and identified more than 75 priority clusters. And as of June 2017, sequences were available for more than 270,000 cases nationally. Next slide. So cluster investigation is critical. And why is that the case? It's really important to determine the underlying transmission cluster and risk network. As I showed you before, what we get from molecular analysis is often the tip of the iceberg. And we need to identify people with diagnosed infection that didn't have a sequence included in analysis, but could be contributing to ongoing transmission. We also want to identify partners in the network that haven't received a diagnosis of HIV infection so that we can encourage them to get retested and initiate appropriate prevention efforts. Cluster investigation also allows us to determine characteristics of the cluster that could be contributing to ongoing transmission that might be amenable to larger scale or structural changes, and then implement public health interventions tailored to the characteristics of the cluster. Next slide. So this is actually a figure that is included in the cluster guidance that we issued earlier this year. And it just gives the sense that investigating a cluster and intervening in a cluster are not at all mutually exclusive activities, that these are very much intertwined. And so one of the things that we're suggesting is that the first step once a cluster is identified is to ascertain the known transmission cluster and risk network. And then step 2 is to initiate critical initial interventions. So for example, this might mean reinitiating partner services for people who never received partner services, engagement and care efforts for any HIV positive persons who don't have evidence of viral suppression. And so those things can get started while the jurisdiction is continuing to investigate the cluster by identifying available sources of data, any important variables that should be captured, and analyzing those data. And then those data can be used to help identify additional interventions that might be useful, such as social network approaches to testing, or additional interventions such as targeted outreach at venues, communication campaigns, communicating with providers, etc. Next slide. So again, I just wanted to mention that we want to intervene in the entire network as appropriate. Next slide. And so as a result, the individual level interventions might vary by what type of person we're dealing with. So some people might have diagnosed infection and be in care but be unsuppressed. And so efforts to promote viral suppression and work with providers might be useful there. People who are not in care, we could initiate more standard data to care efforts People with undiagnosed infection, we really want to try to get to them with testing so that we can make them aware of their status and link them to care. And then HIV negative persons could potentially be offered PrEP, given that they're in a network with ongoing transmission. Next slide. There are also cluster level interventions that could occur. I mentioned a couple of these, maybe some targeted outreach. If a cluster is in a remote location, it might be important to educate providers on testing and treatment. There might be need for collaboration for multi-jurisdictional clusters. Certainly, if there's a cluster associated with injection drug use, it would be important to ensure or expand provision of syringe exchange and substance use treatment. And then potentially communication efforts with population at risk about reducing risk. Next slide. So I wanted to just give an example. I mentioned that we had done that analysis of data from December 2015 and found 13 clusters. There was one cluster in Texas that was particularly concerning. As of that initial data run, it had 18 people in it. And as of a data run from a data set 6 months later, it had grown to 24 members. And these 24 persons were primarily young Hispanic Latino MSM in one metropolitan statistical area. And so CDC and Texas Department of State Health Services partnered to investigate through abstraction of medical records and partner services records. Next slide. So you can see on the left here, there were 24 molecular cluster members. And once we looked and found other people who were sexual or needle sharing partners of molecular cluster cases and their partners, we found an additional 87 people who were possible cluster members. So this indicated that the cluster was much larger than originally recognized. And despite high levels of risk behaviors and large numbers of partners, no patients had previously taken PrEP. Some patients had not been tested using the appropriate algorithm, which indicated a missed opportunity to diagnose acute infection. So prevention efforts that were implemented to improve health outcomes and prevent transmission among these networks included identifying persons in the cluster who were not in care for HIV and attempting to re-engage them in care, retesting all previously negative partners, communication to healthcare providers about recommended testing algorithm and PrEP, and increased funding to expand testing and PrEP in the affected area. And so this was a great example of how we found both possible individual level interventions, but also sort of bigger picture information that was really useful for the state in how they focused their prevention funds and their prevention efforts. Next slide. So as I mentioned, we released guidance for detecting, investigating, and responding to transmission clusters in March, and we're continuing to expand a collection of nucleotide sequence data. We also have launched Bioinformatics Tools to automate analysis and visualization of molecular data at the state and local level. So some of you may have heard of Secure HIV Trace. It's basically a web-based tool that allows HIV surveillance programs to analyze their own nucleotide sequence data without having to wait for CDC to process it. Next slide. So in summary, molecular analysis provides an opportunity of recent and rapid transmission. And using molecular surveillance data to identify, investigate, and intervene in recent transmission events can support efforts to improve health outcomes and prevent transmission among these networks. And it may allow us to make progress in reducing new infections in populations that have not yet seen reductions in incidence. So we feel like in general, this is a powerful tool to help target the interventions that we know are effective, such as engagement in care, HIV testing, and PrEP. Next slide. So I just wanted to end by showing this figure. This is an infographic that DHAP has put together to indicate their priorities in 2017 moving forward. And you can see that they have priorities in terms of increasing knowledge of HIV status, preventing new infections through PrEP, reducing transmission through viral suppression, SSPs, et cetera. And that there's this new one at the bottom, which is rapidly detect and interrupt active transmission through cluster detection, investigation, and response. So DHAP is really supporting this work and feeling like it's an important way to go in the future. Next slide. And these are just my acknowledgements, and I want to thank you for listening. I'm happy to take any questions.
Okay. For for questions, your line is open. So if you have a question, we're a small group today. Feel free to go ahead and ask your question. Okay. Alexa, I will go first. Some of the concerns that we've heard are around confidentiality and transmission of the data. Can you talk a little bit about how the data is transferred to CDC and how you guys protect that data?
Sure. So the data that we get that we use for these analyses comes through EHARS, through standard EHARS data submission, which clearly is under very rigorous security and confidentiality protections. And we protect those data here on secure drives with limited access, only to people with appropriate training. We only analyze these data from within the building. And so essentially all of this is exactly the same as what we do for all of our surveillance data. Now, when we create these cluster snapshots that I mentioned, it does have, and I'll just mention, CDC never gets identifiable data. We never get name and social security number and address and all of that information, as I think you're all aware. When we generate cluster snapshots, that does have line listed information, again, without identifiers, but it is line listed information. We suppress any data that come from another state. So let's say that we have a cluster in state A, and there are some people in that cluster from other states. We suppress the relevant information from those states. And then we transfer those cluster snapshots back over SAMs, encrypted through secure networks. So we essentially, we have very strong protections in place for our standard surveillance data, and those have generally been exactly what we've used in terms of data security. We do recognize that there is inherently sensitivity around these types of data. And so we've encouraged the health departments we've been working with to think carefully about who really needs to have access to the full cluster information, and who maybe needs to know part of it, but not all of it. And this is a principle that applies to surveillance data as a whole, is that you should be limiting access to the people who need to know that information. And so we certainly encourage them to do the same around that. Now, in terms of when it comes time to actually do interventions, what we're finding is that most of the states that have been implementing interventions have not really been doing anything different than they would do as part of standard data to care in many cases. And so they're not going out to individuals and talking to them about the fact that they're in a cluster. They're typically, using that as as information to help prioritize their efforts, and then implementing linkage to care, re-engagement, that type of thing in the way that they might otherwise do through other programs.
Great, thank you. Any other questions from the group? Okay, I have one more. Alexa, would you happen to have any recommendations for online resources or even offline resources about this topic for others who may not know much about it? We do have a diverse group meeting on Sunday and Monday to discuss the topic, so I was just wondering if you had recommendations for other resources on the topic.
Yeah, sure. We actually have a webinar that was posted online, and I can send you the link afterwards that you can share, that is an introduction to HIV evolution. And it was presented at our National HIV Surveillance System grantees meeting in March. But basically, it kind of walks through the very basics of how HIV evolves and why we can use this type of analytic approach to understand clusters. So for people who are more interested in the methods piece, that would be a great resource. The other resource that I would point people to is the cluster guidance that I mentioned a couple of times that we have released. It's also an attachment to the new NOFO, and so it's available on the NOFO website. And so it actually talks through a variety of things, including the background of why this works, how do we identify clusters, how do we prioritize clusters, a lot more detail than I went into today about investigation and intervention. It has a chapter on how to protect cluster data and what are the unique considerations for that. And then there are a number of attachments that go into more detail on a lot of that information as well. So that actually is probably, I would switch the order of those and say the cluster guidance is probably the best place to go first. And then if people are interested in understanding more about the science behind it, then that webinar would be a great resource as well.
Okay, great. Thank you.
Webinar on Alexa is available.
Okay. Any other questions from the
group? It's to be over though.
Okay.
Really quick.
Can you guys mute your lines? Okay. Well, if there are no other questions, I just want to thank Alexa for taking time to share her work with us. And before you guys log off, please take a moment to check the chat box and complete the survey. It just takes 10 seconds. It's only 2 questions. So if you have time, click the link in the chat box and complete the 10-second survey for us. And that's it. I'll be sure to post the resources that Alexa mentioned to our website. So check back to uchaps.org/membership meeting when you have a moment. Thank you guys. Have a good day. Thanks, Alexa.
Thank you.